Welcome back. I shall now be discussing regarding malabsorption syndrome. Most of the topics in GI tract have an overlap with either pathology or with surgery, but this is a pure internal medicine topic. So I would like you to listen to this topic with lots of care, and this will help you improve your strike rate in this topic. I want to first emphasize that because there's going to be damage to the mucosa of the gut, therefore the osmotic load is not going to be absorbed. Therefore, most of the cases of malabsorption syndrome will be having osmotic diarrhea. In fact, lots of time in the exam they use terms like diarrhea responsive to fasting or diarrhea non-responsive to fasting. So let me first explain that to you. You see, when it comes to secretory diarrhea, which is commonly seen with pancreatic tumors like gastrinoma or a insulinoma or a glucagonoma, you would be having opening of water channels. So even if a person will stop eating, still the water channels would be opening under the impact of various hormones. As a result of it, secretory diarrhea is always gonna be non-responsive to fasting. But the topic that I'm gonna explain to you, malabsorption syndrome, here it's mainly gonna be an osmotic load related to sugar and fat, mainly the sugar component. So this sugar is going to be unabsorbed, it will draw in water, and therefore we will be having osmotic diarrhea that would be responsive to fasting, because if person stops eating or takes minimal amount of food, and especially if you avoid the carbohydrate component, because there would be no osmotic load, no drawing of water, and therefore the diarrhea of this person will disappear. So I want you to be very clear about these two terminologies that I've just highlighted, repeating them once again. Secretory diarrhea is a terminology that will be very commonly read by you with respect to pancreatic neuroendocrine tumors. On the other hand, the current topic that we are studying will be having mucosal damage to the small intestine primarily. As a result of it, because the osmotic load is not gonna be absorbed, it's gonna draw in water, and therefore our patients will mainly be having osmotic diarrhea, and therefore he will say diarrhea. I'm writing alphabet R, which means responsive to fasting. And I repeat my statement, when it comes to secretory diarrhea, he's usually gonna use the term diarrhea non-responsive to fasting. Next, I'm going to talk about some more basics. You are familiar with the fact that duodenum is the primary site for absorption of iron. So because this area can be damaged in malabsorption syndrome, like in celiac sprue, you mostly will be having damage to the duodenum and the jejunum, and duodenum being the primary one affected, therefore the absorption of iron will be hampered, and therefore serum ferritin levels will be also reduced in the patient. Similarly, you are familiar with the fact that folic acid absorption occurs both from duodenum and jejunum, but if you ask me to give a single best response, it would be folic acid deficiency that is occurring due to jejunal damage. As a result of it, we will have to do some tests also that would help you identify there's a folic acid deficiency. Similarly, ileum, especially the terminal ileum, is the site for absorption of vitamin B12. So if there's a disease of the ileum, like I'll speak about bacterial overgrowth syndrome. I'll explain what I mean by the word bacterial overgrowth syndrome as we progress in the discussion. But at the moment, I want you to understand that because ileum is the primary site involved in bacterial overgrowth syndrome, B12 levels in the body will fall, and we will have to do workup for the patient. What I mean by workup is that for vitamin B12 deficiency, the traditional test that we read is Schilling's test. However, in reality, lots of times Schilling's test may not be available at your hospital. No, if you're talking about a tertiary care hospital, some hospital like AIMS or PGI Chandigarh, that's where we can, still anticipate Schilling's test to be available, though even in tertiary care hospitals, mostly in the world, this test is not available because of the concerns related to the radioactive tracer related to this particular test. So for academic reasons, Schilling's test is gonna look very great, but in reality, it's hardly done. So in clinical practice, what am I doing? I'm doing a serum vitamin B12 level in the patient, which will be lesser in a patient of bacterial overgrowth syndrome because ileum is the one that is affected. Lots of time to test your biochemistry component. He may not write the serum vitamin B12 because it's very, very obvious. So he is gonna write tests like serum homocysteine levels, or he's gonna write terms like MMA, that is methyl malonic acid levels, which are elevated. So do remember these surrogate methods that the examiner will deploy to ask you regarding damage to the ileum. I said three things: B12 levels are lesser in the serum, homocysteine is elevated, MMA values are elevated. It tells you that the ileum is the one that is worst affected. When it comes to folic acid deficiency, the standard test that we do is RBC folate levels. But again, the point is because he will write the word RBC folate, it's gonna be a piece of cake for you. So to test your biochemistry, he can write this test, no, FIGLU. That is gonna be for amino. It's I would stand for amino glutamic acid test, and along with that, as I said, it can also be written as RBC folate. Though, it's unlikely to give straightforward things. So that's why, you should be knowing about these unconventional terminologies also. And for iron being malabsorbed, you would be having serum ferritin of the patient being significantly and substantially reduced. Now, once we get this data right, I also want to highlight because they can be fat malabsorption, there would be steatorrhea in a patient. So fat soluble vitamin levels will also be reducing, that is vitamin A, D, E, and K. So there's a distinct possibility that he can talk about purpuras, or he can talk about bone pains because of the osteomalacia component that would come up in the patient. Now, since the primary complaint of these patients is osmotic diarrhea, it's my job to next explain to you that how would I identify carbohydrate malabsorption, what are the investigations that would help you to be sure about the diagnosis. We'll talk about the ideal test, we'll talk about the screening tests which are available. And you see, some of these tests would be invasive, some would be non-invasive, and we first prefer non-invasive tests. The non-invasive test that you're gonna read in multiple choice questions is called as D-xylose absorption test. You are aware xylose is gonna be a pentose sugar. It's not gonna be absorbed from the gut mucosa. If the mucosal damage is present, this mucosal damage could be due to antibodies. This mucosal damage could be due to organisms like E. coli or Giardia for that matter of fact. But once there's a mucosal damage, then this simple pentose sugar is not gonna be absorbed. So this is initially a screening test. The problem is that if you are gonna call up any good laboratory in your city and ask them to get a D-xylose absorption test done for your patients, they'll just say that, sir, we do not do this test. So let's look at what are the alternatives available before you so that you can make the diagnosis of your patient. Additional test that I can mention here and is, I think, very frequently used is breath hydrogen test. Like you guys are familiar that breath urea test can be useful for diagnosis of H. pylori, including eradication of H. pylori can be determined by breath urea test. Here I want to highlight breath hydrogen test helps you to determine carbohydrate malabsorption. The ideal test that should be done is a small intestinal mucosal biopsy, but as I highlighted, invasive tests are something that patients and parents, I'm talking about parents because celiac is gonna be a pediatric profile. So if you talk to a mother and tell her that, you see, I suspect that your child has malabsorption, I wanna do a biopsy of the small gut, she may not be so receptive to this suggestion in the initial consultations. Obviously, as you will gain the trust of this mother, she'll be more comfortable and she would definitely like you to explain what is the workup that you're gonna do in case of a celiac guru. So yes, the best test is small intestinal mucosal biopsy, but because of the invasiveness component, I have not written it first. I said I can start with non-invasive tests initially. Another test that you will read, sometimes written in multiple choice questions, again in pediatrics, is stool for reducing substances. Meaning the word reducing substances would be sugar in the stool. You see, I'm saying a surprising thing because normally you read about sugar in the urine, no? You read about sugar in the urine in diabetes mellitus. Now I'm teaching you sugar in the stool. That is stool for reducing substances. Positive basically means there's sugar present which is contributing to the osmotic diarrhea component. They have used another test where they have used xylose with radioactive carbon, that is 14C. So you might retest like 14C D-xylose breath test. So there are two breath tests that I have actually explained to you. One is gonna be linked to radioactive carbon. Second is breath hydrogen test. And anyway, radioactivity is something that, people are not very comfortable with sometimes. So when you're gonna talk about this, a radioactive isotope, educated people might again be having relatively less acceptance. So I have in this particular discussion in these 5 points tried to highlight two things. If the question simply says, what is the screening test to be done, then the conventional answer that is given in most of the books is D-xylose absorption. If they say what is the best test, what is the investigational choice to diagnose mucosal disease, it's gonna be a small intestinal mucosal biopsy. We also have tests in between with fair amount of accuracy that can help you in diagnosis of this condition. Lots of people of carbohydrate malabsorption will have bloating. They will have borboigamy, that is noise coming from the tummy. You see, even when you and me have a meal, then if you're lying in a quiet room, especially after a heavy meal, you might be hearing some sounds coming from your abdomen. That's your peristaltic waves that are contributing, gut movement that is contributing to the sound. But in these patients, that will definitely be exaggerated. I will next explain to you regarding how would you work up a person having fat malabsorption. Well, these patients will be having manifestation called as steatorrhea, or instead of saying steatorrhea, he will use the word greasy, bulky, foul-smelling stools. The stool will be difficult to flush away. The person will say, like, he goes to the washroom, he has to press on the flush button twice, thrice, then the fecal matter is washed away. I hope you recall I explained to you that in melena, there's gonna be a black tarry stool that's gonna stick to the toilet seat. So again, the person will say that the stool, he has to press on the button, the flush button multiple times to flush out the stool. So I'm talking about two stools which are difficult to flush away. and the person will talk about this when he is describing his bowel habits there. So fat malabsorption is the standard presentation of steatorrhea, and along with this, even deficiency of vitamin A, D, E, K can be associated. Now, one of the tests which is available for this condition is a 24-hour fecal fat estimation, but you can understand that for this you have to collect the stool of the person for 24 hours. No? So first imagine the plight of the patient. I mean, he's saying, sir, you mean that I need to collect my stool in a box? He's considering it very unhygienic. And he says, sir, I'm not very comfortable with this. So the acceptability part may be limited here. And even if you convince somebody, now imagine this packet containing stool has reached the laboratory. Imagine the facial expression of the laboratory technician when you ask him to open the pack and do this estimation of 24-hour fecal fat estimation. I mean, this guy is saying, sir, I want to realize, I mean, you are making me do such a smelly and unhygienic test. So we need to use technology to our advantage. Well, what is the technology that we can use here is a breath test. I can put up as a question to you here. Can you tell me a breath test for fat malabsorption? Well, you should be aware of this, that we have a test available in the name of breath triolein test. This is gonna help you in identifying fat malabsorption. So most of the time, there is a distinct possibility that when you read up these questions of malabsorption syndrome, he's going to talk about various investigations also, like ferritin versus fig glue test versus, let me say, methylmalonic acid levels. So when you look at those tests, it would tell you which part of the gut is involved. And along with this, obviously the tests that I've written on the board here, like breath triolein, breath hydrogen test, these are obviously important ones from the exam domain, in a sense that they can help you identify this, and you get a fair amount of idea about what substance is being malabsorbed in this case. Now, before I describe the first disorder, that is celiac sprue related to malabsorption syndrome topic, I would just like to show you an image in which you can see this blue bag, and you can see the mouth of the patient who's blowing into this bag. The test that is being done in this case would be called as breath hydrogen test, and as I've sensitized you, this would be helpful in identification of carbohydrate malabsorption. When it comes to celiac sprue as a topic, you will get this topic questions both in medicine as well as in pediatrics. Well, this is due to the antibodies which are causing damage to the microvilli. So the brush border epithelium in the gut is damaged. If the surface area responsible for absorption is lesser, sugar won't be absorbed, and that explains the osmotic diarrhea component. Well, lots of time you will read terms like gluten sensitive enteropathy, or simply the word gluten enteropathy. Sometimes he might write the word gliadin sensitive enteropathy. So these are surrogate and alternative terms which are used in the exam. When I look at the basic information, you see you are familiar that in all babies we should be going in for exclusive breastfeeding. That is before 6 months of age. So the clinical presentation of this disease will begin after 6 months. That is when you start introducing complementary feeds in the child. At this junction, I also want to highlight that lots of time, especially in a hot Indian summer, a mother might be giving water, or might be giving honey, or might be giving nutritional supplements to the baby even before 6 months of age. I'm just mentioning a accessory extra point here from my perspective, that they mentioned that a mother is giving vitamin supplements and honey to a 3-month-old child? Well, it's obviously not recommended because honey can contribute to botulinism and water is anyway not required, supplements are not required. Breast milk is more than adequate for a baby less than 6 months of age. He said, what is the practice of giving water to a baby before 6 months of age called as? We call it prelactal feeds, and prelactal feeds are contraindicated. In fact, you can relate to this better if I say that suppose it's a construction worker mother and she's working in this NREGA scheme where they have to dig up roads and tunnels, etc. So in a hot Indian summer, this mother is working at 45 degrees Celsius temperature and this little baby who's 3 months of age is under the shade of the tree. I can give an example of a construction worker mother. She's working in a hot Indian summer of 45 degrees Celsius. The baby is under the shade of a tree and she's asking you, doctor, can I give water to the baby? I told her no, but this mother, she purchased a bottle of Bisleri. She gave water to the child. First time it's gonna be okay, but next time she may not have money to buy a new bottle of Bisleri. So the Bisleri bottle will still very much be present, but in that tap water would be present. And when she gives it to the child, he'll obviously have loose motions, he will have diarrhea, he might even die. So the point is that we are not supposed to give anything to the child less than 6 months of age. And from the nutritional perspective, breast milk will be having sufficient amount of calories, that is 65 kilocalories per 100 ml. But for the first 6 months of age, this is okay. But after 6 months of age, this caloric requirement will tremendously increase and the calories in the breast milk will be insufficient. So what are you gonna advise? You're gonna advise complementary feeds for the child. You see, earlier the term used was weaning. The meaning of the word weaning was that you stop breast milk and you start giving solid feeds. But now the concept is that you continue with breastfeeding in a child up to 2 years of age, and along with that cereals should also be given, and that is when the problems will start, because all the standard cereals that we use in India or in America, they all will be having gluten component present in the cereal. The moment you introduce cereals in the child, that is when problems will occur. The child will start having loose motions. So earlier I was saying that if you are giving contaminated water to the child, they would be loose motions. But now after giving the standard cereals, the child is allergic to the gluten component present in the cereals. Either he will write the word gluten, he can write the word gliadin, or he can write it as slash as I have highlighted. Because of the allergy to this gluten component, the body of the child will produce some antibodies. And this is again an important part of this discussion because the antibody seen here is called as anti-TTG antibody, that is anti-tissue transglutaminase antibody. And once it is produced, the bad news is it will damage the brush border villi. It will decrease the absorptive surface area. The end result is that the osmotic load would not be absorbed properly, and therefore the child will start suffering from loose motions. He will say categorically, doctor, since I followed your advice, every time I give some solid feed to my child, the moment I give some solid feed to the child, my child starts having loose motions. So she's indirectly blaming you. So obviously you will tell her that by looking at the face of your child, I can't know that your child is allergic to something. The bottom line is that the MCQ of celiac proof will always begin with a child who is older than 6 months of age. For cereals, you all know this mnemonic, that is brow, So I can just write them for the sake of completion. That is barley, then is gonna be rye, then is gonna be oats and wheat. These are the 4 standard cereals which are gonna be used on a global basis, and intake of this is gonna contribute to problems in the child. Let's now look at how the case-based scenario will be given to you in the question. I today have an anxious mother. She's brought her child maybe for a routine vaccination. The child is older than 6 months of age. This child, she's saying that my baby is not gaining weight, because you see, every time the child comes for vaccination or for any consultation whatsoever, you always check the weight of the baby and you plot that on the growth chart which is present in the healthy baby card. Now this mother, she's an educated one, she's following the growth of her child, and she says, Doc, till 6 months everything was fine, but now I don't know, since I have started giving cereals to the baby, he's not gaining weight. She thinks that cereals have some problem. She's saying the word, the child is becoming malnourished. But as you are aware that before 1 year of age, we don't use the term protein energy malnutrition. We rather use in infants the term FTT, that is failure to thrive. Either the question will use the term FTT or can use the term persistent diarrhea, and she has been to maybe 1 or 2 physicians or pediatricians, and there has been not any substantial improvement in the condition of the child. She is also telling you that my child is looking pale. You see, a mother can definitely pick up that earlier her baby was relatively pink. But now she says, doctor, look at the palms of the child or the soles of the child. He looks so white. Well, for every mother, her child is always a weak child. But here she is specifically emphasizing that the palms of the child are becoming pale. Why this is so is because this disease has a predilection to mainly affect the duodenum. So iron absorption is gonna be hampered. As a result of it, since there is iron deficiency, pallor would occur in the child, and iron deficiency anemia killed children. They always and mostly have delayed milestones. So most of the time it would be delayed motor milestones. Like normally you are aware from pediatrics, child would start sitting with support, then standing with support, then standing without support, and then walking. So all motor milestones definitely can be affected in patients with severe anemia. The type of anemia that will be encountered in this case will be due to iron deficiency. So I'm going to call it a microcytic hypochromic anemia. If this disease is afflicting also the jejunum, then folic acid deficiency can occur. This will contribute to macrocytic anemia. So do not be surprised if in a question he mentions dimorphic anemia for this child. The etiology I've explained, it would be a combination of iron and folic acid deficiency. I've just put 2 arrows to highlight that duodenum in this disease is relatively more severely affected than jejunum. I'm not saying the fact that ileum is spared, it is ileum that is less commonly absorbed. So B12 deficiency is less likely or unlikely to be seen. I repeat the fact again, this disease mainly affects proximal part more than the distal part. So B12 deficiency may not occur to a substantially severe level to result in macrocytic anemia or development or neurological features, because you are aware that vitamin B12 also plays a role in formation of myelin. And if there's a demyelination occurring of heavily myelinated tracts, then we also have neurological features. But in this disease, because usually ileum is mildly involved, or not grossly involved, I can therefore say that macrocytic anemia, primarily due to B12 deficiency or any kind of neurological features, would not be encountered in this child. Now, we have to do some tests by which we can identify this condition. This mother might be initially hostile to you. She might say, doctor, you are responsible. You see, I mean, Indian patients anyway have a habit of blaming everything on the doctor. But here, most of the time, you will have to be at least, I would say, patient with this mother, because she is pretty worried about the growth pattern of her child. The test you gonna write initially is called as anti-TTG antibody, and we can even measure the titer of the antibody as of now, that is tissue transglutaminase antibody. When I was a student at your age, I used to read some alternative terminologies also, which I would just like to share with you. It is not that these tests are not done. They can also be done as of now, like anti-endomyosil antibody or anti-gliadin antibody. But when we compare the disease severity and the prevalence of the disease with the antibody titer per se, the first antibody that I've written, TT antibody, should be the single best response in the MCQ. Coming to the investigational choice for this condition, we will be doing a small intestinal mucosal biopsy. Well, this test will have to be done 2 times in the patient, one initially and then would be repeated after 4 to 6 week period. You see, when I'll do this small intestinal mucosal biopsy initially, when the report will come, it will always mention blunting of the villi. Now I will tell the mother that you are to stop giving cereals to the child. So we are basically doing a gluten elimination from the diet. It has to be 100% gluten elimination. Nothing related to the 4 products related to the name bro that I explained to you are to be given to the child, and after a duration of 4 weeks. A repeat biopsy will be done in this case. Now let's look at what will we talk about the repeat biopsy findings. We will be able to demonstrate regeneration of the villi. I would like to highlight this fact that both things should be demonstrated in the person. Initially, a flattening of the villi after a strict dietary elimination of gluten from the diet. There should definitely be a regeneration of the villi. So if both of these things are demonstrated, that is when we say that this is a confirmed diagnosis of celiac stool. In fact, I can just show you 2 images here also that would help you appreciate the facts relatively better. You see, this may be the initial profile of the patient. If you look at this image, you definitely will notice the goblet cells and the villi look relatively flattened. And now compare this with the second image that I'll just bring on the monitor now. You will now notice that in the second image, the villi have that characteristic finger-like appearance. As you can see here, the finger-like appearance is more pronounced in the image on the right. So this is before and after image that I've highlighted before you, so that, and lots of time this has happened in the exam that they've given 2 histopath images and most guys said, sir, at least we could make it out that it was GI. And then the characteristic feature that you have to identify is the flattening of the villi. I mean, the standard finger-like projections is gonna be missing. So this is before and after report that I've highlighted before you. and along with this anemia component, failure to thrive present. I mean, there's gonna be so many hints in the question that it is very, very unlikely that celiac group can be missed. And I'll put it even simpler. You see, whenever you talk about malabsorption syndrome in pediatric case, first differential diagnosis is always a celiac group. Coming to the treatment part of this condition, the mother is asking you, sir, you have asked me to stop cereals. What should I give to the child? So one of the cereal that can be given to this child is quinoa. Now quinoa is a little expensive one. You see, most of the time when I can just show you an image, in fact, again related to quinoa. You see, one packet of it might be as much as 500 rupees. And it's obviously horribly expensive. I mean, in India, to expect a mother to purchase quinoa for the child is a little far-fetched, I would say. So, yeah, I mean, if economic issues are not there, yes, we can use quinoa for this condition. But lots of time, I mean, the economic constraints will be very much present for this condition. So let's look at what can be used alternatively in place of quinoa. That would be maize. I also want to tell you, and what I say next, please do not note down. I repeat my statement. Please do not note down my next statement. Just listen to me here. You see, lots of time you might be telling the mother to give dosa, idli to the child. That is rice. Rice contains gluten but in minimal amounts. Rice contains gluten in minimal amount, but in very poor families where they're not gonna be able to purchase fancy stuff, and you see maize may not be available round the clock in India or round the year around in India. So every month it may not be available. So the end result is that quinoa is preferred. It's rich in proteins, or along with that, we can give a combination also to make it economical. Rice is just a point that I've tried to explain to you from the Indian domain, but otherwise in the exam, please do not answer rice. Also, I will give iron supplementation to this child. I will be giving folic acid supplementation to the child. These children do not require B12 supplementation, since I said ileum is either spared or is minimally involved, so that the manifestations are very limited. Now, assuming the fact that the mother has understood everything that you have said, and she's strictly following this gluten elimination from the diet, or I can just write the word strict diet restriction is being followed. So she in the follow-up visits will definitely tell you that my child is gaining weight or the anemia component has become lesser, and she will be, much more relaxed in her subsequent visits as compared to the initial ones, and you need to tell her to continue with the follow-ups. It is important to continue with follow-ups, and you will also tell her that if you will do this very strictly, the severity of the disease manifestations will gradually reduce. Usually by 10 years of age, or approximately by 10 years of age, the disease severity might become so less that once the child is older, you see children when they are 13, 14 years of age, once they start, going out, the child might say that I want to go out and have a pizza, or I want to go to somebody's birthday party and I want to eat some snacks, etc. You see, initially this child was on dietly strict restrictions, so we were not allowing any outside food, restaurant food. It was pure home cooked food for the child. Either it was quinoa or it was maize for the child. But after 10 years of age, if the severity of the disease is becoming lesser, once in a while, if a child wants to go to a birthday party and have something which is obviously not belonging to maize and quinoa, yeah, the child can have it. So the good news is that if you are gonna act initially in an aggressive fashion, strictly fashion, and go for strict diet restriction, the disease severity will substantially reduce. But now why I was emphasizing on the follow-up component was because this child can develop some complications also. One of the very important complications that is asked in multiple choice questions and has been taught both in dermatology and at this moment I am not teaching also is dermatitis herpetiformis. So you will have encountered these questions talking about extraintestinal manifestation of these patients. The leading one is dermatitis herpetiformis. Most of the time, the child will be developing pruritic vesicles on the elbows and on the knees. I'll show you the image also, but I just want you to remember that just like you are comfortable with the fact that Gottron papules are always found on the knuckles. Gottron papules were discussed in dermatomyositis. Gottron papules are always found on the knuckles. I want you to remember if they anytime give you an image of vesicles which are present on the elbow and the highly pruritic child keeps on scratching, so there would be excoriation also. Please appreciate in scabies, the scratching would occur in all over the body, right? Especially over the axilla, over the groin area, between the finger clefts of the person. But in this case, I'm mainly talking about vesicles, which are gonna be itchy on the elbows and on the knees of the patient. Once the image comes in, you will be able to relate to this better. But first, theory is obviously important. So they can sometimes give you a spot diagnosis also. If they give a history of celiac sprue, obviously it's a piece of cake for you. Then you don't need to refer to the image also. But if they do not give the image or cut, but if they give the image alone without mentioning dermatitis herpetiformis, even then you should be able to correct the question. In fact, we will also be going in for diagnosis of dermatitis herpetiformis in two ways. One, I can go for antibody that will help in diagnosis. Second is obviously a biopsy of the skin with immunofluorescence study. When it comes to the antibody, the name of this antibody is anti-ETG antibody, that is anti-epidermal transglutaminase antibody. You see, it might look very easy for you at the moment, but I've seen people mess up between these antibody names in the final pressure in the exam. There are two names that I've told you today. One is double TG, that is tissue transglutaminase antibody, and currently the name that I'm telling you is ETG, that is epidermal transglutaminase antibody. Along with this, the biopsy report will also come. So most of the time you will be biopsy reports with immunofluorescence will always be green. And you will be able to see a breach in the basement membrane, and then there would be lots of immune complex depositions. These immune complex depositions are mainly of immunoglobulin A and the complement. So like in the earlier parts of our discussion, we have talked about fishnet appearance with respect to pemphigus vulgaris. I am today highlighting the fact that if you get a green line which is broken at multiple places with these dots which are greenish in color, again representing immunoglobulin A and C3 deposits, your diagnosis would be what we are discussing right now. I want to emphasize, if he begins by celiac sprue, this will not be any trouble for you. So I want you to have a capacity where even if celiac sprue is not given in the question, the history of malabsorption is not given in the question, spot on, you should be able to identify that the patient's lesion is dermatitis herpetiformis, and this is how it will look. The question will mention vesicles on the elbows. You can see the vesicles which are pruritic. So you can notice lots of erythema present, which are present on the knee joint of the patient. And then is this green line I was talking about, and this shows that spotty appearance. That spots are basically the